I'm Dr. Aditya Amkar. I'm a cognitive neurologist. I completed my neurology training from Jaslov Hospital, Mumbai, and I did a 2-year fellowship learning more about dementias from the University of Calgary in Canada. And I'm grateful to Dr. Sandeep Rane sir for giving me this opportunity to talk on a topic that is close to my heart because my brother suffers from migraine and also my father suffered from it. So I wanted to take this hour to help talk more about migraine. So the learning objectives are very simple to help you understand how to diagnose migraine, understand the pathophysiology of migraine, what to plan when it comes to acute and preventive management strategies, and something about newer agents that are available in the market. So let's begin. So the word migraine was derived from the Greek word hemicrania, which was later converted into Latin as hemigrania, and the French translation of the term is called as migraine. So the take-home message here is the Greeks tried to describe something which involved half the head and not the full head, which is a very important feature to differentiate it from, say, tension type headache. So why should one understand migraine? Migraine is a very common cause of disability and it leads to loss of work and productivity. It ranks as the world's second leading cause of disability, and it affects approximately 12% of the population, which is a high number in epidemiology. So the annual rates can reach up to 17% in women and 6% in men. The prevalence increases during puberty. It peaks around ages 35 and 39, and then it subsequently decreases after menopause. And migraine tends to run in families, and the risk is 40% if one parent has a history of migraine, and it increases to 75% if both the parents are affected. So if in the clinic you have a person who says that they had migraine, that they have migraine and their parents or siblings also have history of headaches, then definitely suspect migraine as the etiology. So how do we define migraine? So migraine is in essence a type of a primary headache, which is different from secondary headaches, which can have other causes which drive them. And to call a headache migraine, there should be at least 5 attacks, and the following features should be there. The headache should last for around 4 to 72 hours, and the headache should have following characteristics. Any two of them should be there. It should be unilateral in location. It should have a pulsating quality. The intensity should be moderate to severe. And the last point is aggravation by or causing avoidance of routine physical activity. How I interpret that point number 4 is any change in your activities of daily living. For example, because of the headache, if you're not able to do your day-to-day functioning, then that would be called as a criteria which is fitting that of migraine. Now, during the headache, if one of the following is the feature, for example, nausea or vomiting, and photophobia or phonophobia, then that is also confirmatory for a diagnosis of migraine. And last, which is very important, is it should not be accounted for by any other type of headache diagnosis. So this is a very important slide which will tie together our future discussions. But the take-home message here is understanding the unilaterality, the pulsating quality, the moderate to severe intensity, affecting daily life, nausea and vomiting, photo and phonophobia. These 6 features are very important to label the headache type as migraine. And I'll explain why these features come. So typically there are 4 phases of a migraine attack, and they progress from the prodrome to the aura, headache, and then the postdrome. Now, understanding these stages is very important for effective management and patient education. So let's begin. What is the prodrome? So the prodrome is also called as premonitory symptoms. So in some studies with people who had regular migraines, they gave them detailed migraine questionnaires. So they would document every day what were the things that they were doing in that day. And then at the end of the month, they would try and collect what are the triggers and what are the symptoms that the person was having. And from those studies, they found that about 77% of patients had typical symptoms 24 to 48 hours before the headache onset. So the localization of these symptoms begin in the hypothalamus. I'll explain the science behind it. And the common symptoms are those of yawning, mood changes, lethargy, neck stiffness, sensitivity to light sound, craving, thirst, and some difficulty with focusing vision. So you can see that cravings, thirst, lethargy, mood changes, they can all map onto hypothalamus. So this was a paper published in the Journal of Brain activations in the premonitory phase of NPG triggered migraine attacks. So what they did is in about 30 patients of headache, uh, GTN or like, and they tried to activate their head. By doing that, they realized that most of the activation that you have is still part of the hypothalamus. Sorry for that. So coming back, so this study showed that the premonitory phase is largely driven by changes in the midbrain and the posterior inferior part of the hypothalamus. So even before the headache begins, there are changes noticed in those parts of the brain region. Then comes the next phase. The next phase is that of aura. So approximately 25% of cases tend to have aura, and they're typically gradual. They last for less than an hour, and by definition, they must be fully reversible. So these auras often precede the headache and can sometimes occur simultaneously as well. So these gradual onset visual disturbances can appear as zigzags or scotomas. In our textbooks, they are called as a Greek term of fortification spectra. Sometimes they can have sensory changes of paresthesia, tingling in their arms or legs, and they can also have speech or language impairment. So the underlying pathophysiologic mechanism is very interesting. It's called as cortical spreading depression. So way back in 1944, the Professor Leo, who was a Brazilian physiologist, he was working in Harvard under Hallowell Davis and was experimenting on rabbits who had exposed cortices. He applied mechanical and electrical stimuli and noticed that there was a very slowly propagating wave of suppressed electrical activity which spread across the cortex at a rate of about 2 to 5 millimeters per minute. And this was followed by a transient hyperexcitability. So he coined the term spreading depression of activity in the cerebral cortex, or simply called as cortical spreading depression. So what we can see in this image is that as the wave propagates itself at 2 to 5 millimeters per minute, this part of the brain with the smaller waves. So suppose you put EEG electrodes on the scalp, the part which is blue, you would notice flattening of the EEG waves, whereas the part which is pink, you will have hyperexcitability or normal features there. So it is driven by changes in potassium at the ion channel levels. And it was very unclear what is the pathophysiologic mechanism which drives migraines. And in the past, it was largely popular to believe that migraines were driven by changes in the blood vessels, so spasms followed by dilatation. But now, from the 1990s onwards, evidence has started accumulating, which show changes on functional MRI scans and PET scans, which correlate with cortical perfusion changes during symptoms of aura in patients. So today, cortical spreading depression is now accepted as a physiologic substrate for migraine aura, and this later on triggers the trigeminal activation, which links aura to headaches. So this is a cartoon figure which shows that in this diagram, the cortical spreading depression begins in the occipital lobe and over a few minutes gradually extends anterior. So imagine if the symptoms begin here in the back part of the brain, which is the occipital lobe. The occipital lobe is involved in processing visual information. So as the cortical spreading depression starts, they might have fortification spectra and the scotomas and the zigzag lines that they see. As it progresses forward, as it involves the parietal lobe, we can see that they'll have tingling or paresthesia in the limbs. And as it crosses over to the central gyrus, then there might be numbness or motor weakness, which can be transient as well. And if it further proceeds forwards to the Broca's area, then you can have speech difficulties during the same aura episode as well. So this cortical spreading depression is very important to understand the symptoms of aura that happen in migraine. The third phase, the most important phase, which bothers everyone, is that of headache. It is often unilateral, pulsatile, or throbbing, and it increases in intensity within the first few hours. The intensity correlates with the nausea, vomiting, photophobia, phonophobia, and osmophobia, and is often worsened by movement. This pain typically resolves with sleep. So the reason people have a lot of nausea and vomiting is because the same cortical spreading depression that we showed in the brain. There is also a similar wave which passes through the vagus nerve and the stomach becomes slow, or there is stasis. The stomach is not able to propagate its waves ahead. So there is no peristalsis. And that's why there is a lot of nausea and vomiting which can happen during episodes of migraine. So the pathophysiology of headache is that of activation of the trigeminal nucleus. So what I want to highlight in this image is the peripheral sensitization of these blood vessels which exist in the dura as well as the dura. So the brain itself does not have pain receptors. It's the covering of the brain, the meninges, which have the pain receptors. And it's when there is inflammation that happens in this area. It's a sterile kind of inflammation, a neural inflammation, which I'll explain in a future slide. But it is these changes which lead to the experience of headache. So the term that I'm going to use here, which is very important to understand, is that of peripheral sensitization. So the cortical spreading depression that I showed you, that will drive changes in the trigeminal cervical complex, which will lead to changes at the brain level. So let me help you understand by giving you two examples. Suppose person A has different neurochemicals in their brain, CGRP, neurokinin A, or PCAP, or substance P in their dura mater. The same person B also has the same amounts of neurotransmitter. One is normal, one is having migraine. So the person who is having migraine is more susceptible or more sensitive to the same amount of neurotransmitter in the same brain. So that is what I mean by peripheral sensitization. So the nerves are just picking it up earlier, whereas in the same situation, if there was no headache, they wouldn't have picked up the sensation as pain. And this forms a feedback loop. So once the nerves become sensitive, they take the feedback from the meninges and they drive inflammatory changes by causing vasodilation and inflammatory signs. And that is why it is a unilateral throbbing kind of headache, which is driven by these abnormal electrical pulses. So what is this trigeminal vascular system? So it's a pathway which conveys nociceptive information from the meninges to the cortex, and it is transmitted mainly through the ophthalmic branch of the trigeminal nerve. They originate from the trigeminal ganglion and the upper cervical dorsal nerve roots, and they innervate all the cerebral blood vessels, PL vessels, dura mater, and large venous sinuses. The afferent projections from the trigeminal ganglion converge with inputs from adjacent skin, pericranial and paraspinal muscle, and other C1, C2 innervated tissues as well. And these all synapse and converge on the second order neurons in the trigeminocervical complex. So that is TCC. Why this is important? Because this will help explain the convergence of these afferent projections with neurons from extracranial structures. These account for the referred pain perception in the periorbital, occipital, and the cervical neck regions. So in your clinics, if you have a person who complains of continuous episodic neck pains, then you should always have a suspicion whether this neck pain is driven by a migraine-like circuit in the brain, because the cervical C1, C2 is also converging on the trigeminal ganglion, which is on the trigeminal nucleus, which is taking sensory feedback from the orbital and the face areas as well. So that is the importance of this slide. Now, once it comes to the trigeminal cervical ganglion, then from there, the pathways ascend up to the brainstem, thalamus, hypothalamus, and the basal ganglia nuclei. And these nuclei further project to multiple cortical areas. So somatosensory area, the insular cortex, motor cortex, parietal association areas, the retrospinal area, auditory, visual, and the olfactory cortices. So we can see in this image that the signals which are coming from the sterile inflammation that's going on in the meninges go all the way to the trigeminal ganglion, the trigeminal cervical complex, from there to different areas of the midbrain, hypothalamus, thalamus, and then to the different parts of the cortex. Understanding this is important because then that will help you understand the different cognitive, emotional, and sensory aspects of the pain signals that the brain is interpreting. And that drives photophobia, phonophobia, the cognitive dysfunction, the osmophobia, and the hypersensitivity to pain. So people with migraine during the acute episode of migraine have challenges with planning and thinking. So driving when you are having a migraine is not the best thing to do. Neither is it. You should be cautious while taking big decisions if you are having a really bad migraine episode. So this nociceptive information is also transmitted to limbic system, which explains the emotional response in migraine headaches. Coming to the last phase, the postdrome. So these are the symptoms after the headache has terminated. And the common symptoms are those of exhaustion, some dizziness, difficulty in focus and concentrating. And these are movement vulnerable. So if you move that side of the limb which is having headache, then it worsens the underlying symptoms. So the mechanism which explains these postdromal symptoms are that of persistent central sensitization, central meaning cortical sensitization. The topic I was talking about previously was peripheral sensitization. There can be residual hypothalamic and brainstem dysfunction. There is recovery from the cortical spreading depression, and there is altered dopamine and serotonin signaling as well. So this is a recap of the pathophysiologic mechanism which drives migraine. It starts with the prodrome in the hypothalamus, and then it progresses to cortical spreading depression, which drives the aura. And once you have the cortical spreading depression, then that will drive changes in peripheral sensitization of the trigeminal nerve distribution and also C1, C2 nerve distribution. And that will lead to impulses to the trigeminal cervical complex. And from then it will again spread to the cortex and cause cortical sensitization and increase sensitivity to pain, to normal stimuli to the skin as well. So this is what actually drives the pathophysiology of migraine. So what we can also understand in this image is how does NSAIDs work? So NSAID will also reduce the ongoing peripheral neurogenic inflammation. So it is also called as sterile inflammation because there is no actual antigen which is driving the inflammation. It's just the hypersensitivity of the nerves. So giving NSAIDs will reduce this overall inflammation. Giving drugs like sumatriptan, rizatriptan would also act on the serotonin receptor and cause vasoconstriction. And that will also help relieve some of the throbbing type of headaches. And we'll also discuss CGRP protein in a future slide and what the newer treatment molecules that we can offer. So what are the different migraine subtypes? So they can be migraine without aura as well. So they can be recurrent attacks which last for 4 to 72 hours. The pain is again unilateral, pulsating, moderate to severe. It is aggravated by physical activity. It is associated with nausea, photophobia, and phonophobia, but it does not accompany the aura symptoms, which can be seen in 25% of people. So migraine with aura is the same features, but with symptoms of aura. The aura can be visual, sensory, speech, motor, brainstem, or retinal disturbances, which is then followed by headache. And then we have chronic headache. So chronic headache is defined as headaches occurring for 15 or more days of the month for persisting 3 months. And there are migraine features and more than 8 days per month. So what is to be understood here in chronic migraine is that headaches can be of migraine phenotype or tension type headaches also, or just in general headache and head throbbing, which does not have photophobia, phonophobia, is not unilateral, and doesn't affect your day-to-day activities. So overall, the headache days should be more than 15 per month. But there should at least be 8 days per month which have typical migraine phenotype. Then it's called as chronic migraine. So this is an interesting slide which talks about episodic syndromes which are associated with migraine. I have highlighted the first two because these are commonly seen in our practice in the neurology OPD. So they can be recurrent gastrointestinal disturbances. So they can be abdominal pain, discomfort, nausea, vomiting. So as I explained previously, the cortical spreading depression which is seen in the brain can also cause similar effects on the gastric peristalsis. So if there is stasis of the stomach, whatever acid is generated and whatever food is being eaten is not moving down. And that leads to the sensation of abdominal pain, discomfort, nausea, and vomiting. So sometimes people may have lesser headache, but very severe nausea and vomiting. So that is also an episode, or that is also a syndrome which can be labeled as migraine because the pathophysiologic mechanism is same. So this should be a strong suspicion in people who are having recurrent GI symptoms with minimal headache. So something to be kept in mind. The other is that of benign paroxysmal vertigo. So now imagine that the cortical spreading depression as well as the central sensitization has affected your integrating areas in the brain which integrate positional data that's coming in from your vestibular nerve and from the peripheral nervous system, proprioception. So that will also lead to a sensation of imbalance while walking or imbalance while moving your head. So this is called as vertiginous migraine, and they are brief episodes of vertigo. So people will say कि चक्कर येते हैं, चक्कर येते हैं, डोकं दुखते हैं, चक्कर येते हैं, डोकं दुखते हैं, चक्कर येते हैं. So that kind of phenotype fits with the if there is photophonophobia, if there is the other features of migraine, then you should consider this as vertiginous migraine as well. And these people will also benefit from the migraine therapy that we'll talk about in future slides. Very rare, but can be seen is benign paroxysmal torticollis, where there can be a head tilt during the episodes of migraine. Coming to some complications of migraine, there can be status migrainosis. So this is a debilitating migraine attack which lasts for more than 72 hours. And the other two complications, frankly, I've never seen in my practice so far, but there are textbooks mention it, is persistent aura without infarction. So the aura can last for more than 1 week. We previously discussed that aura generally lasts for an hour and then reverts back, but here it can last for more than a week without any imaging for stroke on the scans. And there can be migrainous infarction as well. So the aura symptoms are associated with real-time brain ischemia, which can be seen on an MRI during a typical attack. So to be honest, I haven't seen these cases yet, but something to be aware of. There can be migraine aura triggered seizures, which we have seen. So seizure can be triggered during a migraine attack with aura. And what migraine typically does is because it is quite severe in intensity, it leads to work disability and loss of productivity. So that itself is a major complication of migraine. Coming to etiology, so it is a result of combination of factors, can be genetic, environmental, different neurological factors. The headaches are linked to abnormal brain activity, which affects nerve signals, neurotransmitters, as well as blood vessels. And there's a very strong genetic component. So the risk is 3 times greater in affected relatives. So even in my family, my brother and father had it. Specific genetic syndromes. So again, very rare, but can be seen. Familial hemiplegic migraine is a described entity which can have mutations in different genes. And they're basically channelopathies which can present with this type of cortical spreading depression and the activation of peripheral sensitization and cortical sensitization. Then we have CADASIL, which is again an angiopathy linked to NOTCH3 gene mutations, which lead to small vessel disease and a lot of tiny strokes in the brain. They can also present with headaches, which can come with auras. So MELAS is a mitochondrial disease, which is a multisystem disorder, and that can also present as recurrent migraine headaches. There are many more genetic syndromes, but these are the most common to look out for. Now, coming to something important, what are the migraine triggers? So triggers can vary widely among individuals. Another retrospective study found that about 76% of patients reported triggers. And patients should always document their migraine triggers to reduce future impact. So if patients can keep a track of what precipitated their headaches, then counseling becomes easy because it is as simple as avoiding the same triggers. So the commonly accepted probable migraine triggers are stress. Stress drives cortisol, stress drives inflammation, stress drives hypothalamic activation as well. Hormone changes are also very common. They occur during menstruation, ovulation, or pregnancy. Skipping meals, hypoglycemic episodes can also drive migraines. Weather changes, pressure changes can drive migraine. Exposure to bright lights, for some people, wine ingestion can cause migraine. So, some lower frequency but possible triggers are excessive or insufficient sleep. Then aspartame. So, aspartame is a food trigger, and cheese is quite high in aspartame as well. Odors like perfumes, cologne, or petrol fumes can also cause headaches. Smoking has been described as a possible trigger. Cheese and chocolates are also food triggers that can precipitate migraine. Other less commonly reported triggers are neck pain, late sleeping, or a change in circadian cycle. So the difference between late sleeping and excessive or insufficient sleep is that here the quantity of sleep is what we are measuring as a possible trigger. Here we are recording the time at which they go to bed. So going late to bed, like say sleeping at 2 a.m., 3 a.m., can be a trigger for migraine in spite of sleeping 8 hours after that. Then exposure to heat or warm weather can be a trigger. Food ingestion, exercise, or sexual activity can be different triggers which are reported. Coming to the role of neuropeptides, so calcitonin gene related peptide or CGRP is a very newly discovered neurotransmitter which is abundant in trigeminal ganglion neurons. It is a potent vasodilator of cerebral and dural vessels, and that is a very important molecule which drives the neurogenic sterile inflammation that I was talking about. It mediates pain transmission to the CNS, and elevated levels are observed in spinal fluid in chronic migraine patients. Serotonin is released from the brainstem nuclei, and the mechanisms are debated, but serotonin levels likely decrease between attacks, and that possibly results in a deficiency in the pain inhibition system. And that's why drugs like serotonin, rizatriptan, sumatriptan, which are 5-HT2B agonists, they help boost serotonin transmission. Then pituitary adenocyclase cyclase activating polypeptide or PACAP. That is also a novel molecule which is being described to be elevated during attacks and may trigger migraines in susceptible patients. So to answer the question, when to do neuroimaging? So the acronym that we are taught is the SNOOP acronym. And these are the typical indications for when to do an MRI. And it should be indicated if there's an atypical headache or a new episode in a person who is above 50 years, or when some of these red flags are there. So red flags like systemic signs or secondary risk factors. So if you see a patient with a rash or vasculitis, SLE features, or if you see that there is HIV or immunodeficiency symptoms that you can see on inspection, or if you see that there are any other red flags, changes of hepatic or renal failure, then you can do brain imaging to see if there is any underlying other mechanisms driving the headache. If there are neurologic signs or symptoms, so if on examination there is a focal neurological deficit, there is dysarthria which is persistent, or there is limb weakness which is residual, not going, then that's an indication to get a scan. If it is described as the acute or the worst headache of life, then it could be a cerebral bleed, or it could be some reversible causes as well, like RCBS. So doing MRI is also important in that. Older patients can have different comorbidities which can lead to headaches. So doing that is also important. And it can be position dependent. So what two differential diagnoses to consider when there is a position dependent headaches is if the headaches are worsened on sitting or standing, then there is idiopathic intracranial hypotension. So the pressure in the CSF is low. If the headaches worsen on Valsalva maneuvers or on lying down or on coughing or straining, then it is idiopathic intracranial hypertension. So the CSF pressures can be high. So in all those situations, doing an MRI is warranted to look for secondary signs on the scan. Now, coming to the most important part of the talk is management strategies. So, effective management combines acute treatments, preventive therapies, and personalized lifestyle modifications. All these three are important. Acute treatment aims to stop progression quickly using a large single dose. Parental medications may be necessary for patients with gastric stasis, nausea, vomiting, because if the stomach is not having good peristalsis, giving oral medications is not going to help because they are not going to be absorbed as quickly or efficiently. So the first line treatment are NSAIDs and aspirin, paracetamol, acetaminophen. So it is recommended for patients in mild to moderate attacks without nausea or vomiting. So options are ibuprofen, naproxen, aspirin, or paracetamol. Why I've showed that cortical spreading depression is because one principle to remember in practice is all these SOS medications that we're giving, the patient should take these medications at the start of the headache. The best results are observed when the person takes it at the beginning of the headache and not when the headache has evolved. Because once the headache has evolved, the circuitry is active. Taking an NSAID is not going to give dramatic results. So, if the patient is used to taking a particular type of NSAID and if it is ineffective, then you switch to some other drug class. So, if the headache is not mild to moderate but is moderate to severe, then triptans are the first line of treatment. And they're especially effective if the patient has allodynia or hypersensitivity of skin. So the options that we have are sumatriptan, which can be given as a nasal spray, subcutaneous or oral, zolmitriptan, which is nasal or oral, and rizatriptan, which is oral. So many of these formulations are available as nasal spray in the market. You can have rizatriptan, which is also mouth dissolving. So you just keep it under the tongue, 10 mg, and it can be absorbed, and there's no need for it to be swallowed. So if it is moderate to severe, then you should be giving them triptans as a choice. Combining NSAIDs with triptans is often more effective than monotherapy. So sumatriptan 85 mg and naproxen 500 mg. So this combination in the market is available in a popular brand called Headset. So triptan safety and contraindications is something you should be aware of. So the use should be limited to less than 10 days per month to avoid medication overuse headache. And the contraindications are because it leads to vasoconstriction, any ischemic strokes, ischemic heart disease, poorly controlled hypertension, angina, pregnancy, and hemiplegic or basilar migraine are serious contraindications to using triptans. So amongst the newer molecules, the drugs approved for acute treatment are only the GPANs. So the GPANs are oral CGRP antagonists. These two are not yet available in the Indian market, but are US FDA approved. So rimegepant and ubrogepant. So consider for patients who do not respond to conventional treatments or those with coronary artery disease. And they are preferred for patients who cannot use triptans due to cardiovascular risk as it does not induce vasoconstriction. And the caution is significant adverse effect is dizziness. Patient should avoid driving for at least 8 hours after taking these drugs. So once they are available in the Indian market, we'll have to review this slide in more detail. Other adjuvant or rescue therapies, which we commonly give in the emergency in the neuro department, are antiemetics. So metoclopramide or chlorpromazine or stemetil prochlorperazine. These are commonly used adjuvants to reduce the nausea and vomiting which accompany that of the migraine episode. Even domperidone can be helpful in this situation. It is a prokinetic which pushes or improves the gastric motility. Avil or diphenhydramine may be added to prevent dystonic reactions with metoclopramide. Then ergots like ergotamine and dihydroergotamine can be available for parenteral use, and they are used in acute situations and are an effective bridge for medication overuse headaches and status migrainosis. So use of DEXA, they can reduce recurrence of early headaches, but they do not provide immediate relief. So giving DEXA in the emergency may not actually benefit the patient directly. So what are the goals and indications for prevention? Preventive treatment aims to reduce the frequency and improve response to acute attacks and reduce disability. So if the person is having more than 4 episodes of migraine per month or more than 8 episodes of headache per month, if the patient is subjectively complaining that doctor साहब दवा दे दो ये headache चाहिए ही नहीं, or if there are no contraindications and there are significant disability and reduced productivity, then in subjective cases also we can go for preventive treatment. So some of the indications are long-lasting headaches, attacks causing significant disability, failure or contraindications to acute therapies, risk of medication overuse headache, and specific type or hemiplegic brainstem aura, persistent aura, or migraines infarction. They are the indications for preventive therapies. So the medications for chronic migraine prevention, which are based on controlled trials, include beta blockers like metoprolol, propranolol, timolol, antidepressants like amitriptyline and venlafaxine, anticonvulsants like valproate and topiramate. And now what are new in the market are CGRP antagonists. So India has erenumab. The company is Novartis is giving Suvire. Suvire is a subcutaneous injection that is erenumab. So you get 70 milligrams. It is to be given once a month. And the indications for CGRP antagonists are if you have tried any of the above two preventive medications and still there is no relief, then you can go for a third line drug like erenumab. So in India, the cost of Suvire is about 20 to 25,000 per month. And that is one injection which is to be given subcutaneously. And the choice of preventive agent should be individualized according to the patient specific characteristics, the comorbid conditions, the medication side effect profile, the medication cost, what the patient wants, their values and preferences. So for women with childbearing age, preventive options include verapamil or calaptin, flunarizine or cybelium. And valproate should not be used because it is teratogenic and is associated with increased risk of birth defects. For patients with hypertension who are non-smokers and less than 60 years of age, metoprolol, propranolol, or timolol are good if there is absence of contraindications. For patients with hypertension who are smokers and who are above 60 years of age, treatment options include verapamil or flunarizine. It is suggested to not use beta blocker as initial therapy for migraine prevention in these patients because beta blockers may be associated with a higher rate of stroke and other cardiovascular events compared with other antihypertensive drugs. So because large observational data sets have pointed to beta blockers causing these side effects, we generally avoid that in above 60 years of age. So for those patients who have comorbid depression or mood disorders, amitriptyline or venlafaxine is a very good choice. For patients with epilepsy, valproate and topiramate are excellent choices. For patients with insomnia, again, amitriptyline is a reasonable option. And those with obesity, topiramate will help weight loss as well as reduce headaches. For those with Raynaud's phenomenon, again, calaptin or cybelium are good options. And all these preventive therapies need to be understood that side effects are common and that may limit the use of these medications. So what expectations should be set for a patient who is receiving preventive therapies? So 50% of patients treated with one of these medications will have at least 50% reduction in the frequency of headache after 3 months of treatment, assuming that they are getting adequate doses. So a lot of times in practice, we see that even if preventive therapies are ongoing, they are not at adequate doses. They can be suboptimal dosing. People come back frustrated that दवा 1 महीने से खा रहे हैं 2 महीने से खा रहे हैं फिर भी असर नहीं हो रहा है. You have to counsel them that you have to take it at least for 3 months, and you don't expect that this migraine circuitry is going to die down immediately. Even if there is 50% reduction in the frequency of headaches, that is also a win-win situation. And again, not all patients are going to have relief with all the medication that we'll be giving them. It is a difficult disease to treat. But if you set their expectations right, then the compliance is better. So what if there is no response to preventive therapies? So in that case, you can consider second-line agents like botulinum toxin or Botox, and you can give them in the areas that are depicted in the image below. So some headache specialists in Mumbai do give Botox as a second-line therapy to those who have failed preventive therapies. And you can also give erenumab or Suvire as we discussed. The cost is prohibitive. It is about 25,000 right now, may come down in the future. And there are other third line agents which can be discussed like feverfew, tizanidine, memantine, pregabalin, cyproheptadine, and zonisamide, which don't have really robust data to advocate for their use right now. So alternative treatments and lifestyle adjustments. If you remember the first slide when we talked that the premonitory phase or the prodrome phase, the pathophysiologic mechanism is the hypothalamus is the one which is showing chronic activation. So the hypothalamus is also the center in our brain which regulates our circadian cycles. So ensuring that you sleep on time, you wake up on time, ensuring your stress levels are adequate, ensuring that you have regular exercise, you do yoga, maybe relaxation therapies, cognitive behavioral therapies, and biofeedback mechanisms. All these will help the hypothalamus be a happy organ and be normal and reduce the chances of precipitating or triggering migraine circuitry. So to talk about the list, making sure that the patient is drinking enough water, is avoiding the triggers that they know can trigger a headache for them is very important. So one more point in the lifestyle is it has to be individualized. So every person's habits are different. Some people regularly sleep late at night, but they get the 8 hours of sleep and they wake up late in the morning. They need not complain of migraine, but if suppose they sleep early, then that can precipitate a migraine. So sticking to your usual circadian cycle is very important. Any changes in that can precipitate a migraine headache. So all these lifestyle changes have to be individualized to the person. Not everyone can follow the same healthy lifestyle checks that we can have. Coming to prognosis, migraines are chronic, but management can achieve significant relief. Early diagnosis and intervention are critical to prevent the progression to chronic migraines. Chronic migraines can revert to episodic migraines in 26 to 70% of patients. So there is hope. If the migraines are really severe and chronic, you can bring them down to once in a time episodic migraine. And seeking a specialist help will definitely help in getting improvement in quality of life. Education and prevention. So patients should be educated on the migraine phases and the benefits of abortive and preventive therapies. They should be offered these options. They should be encouraged to maintain a headache diary so that they can identify the patterns and triggers. The patient should seek medical attention if symptoms worsen or new neurological symptoms occur. And coming to the last slide, take home message. Migraine is a common debilitating neurological disease. I hope in this talk you have understood the pathophysiology of how migraine is caused. And now you know that acute treatment options are NSAIDs and triptans which can be given, including parenteral injections like stemetil and metoclopramide can be given to help with the nausea and vomiting. IV fluids and IV NSAIDs can also be given. Ergotamine injections can also be tried in severe situation. Preventive strategies we have discussed, beta blockers, anticonvulsants, the SSRIs, as well as calcium channel blockers. We discussed importance of lifestyle changes and the need for a headache diary to be maintained. So all the obvious triggers that precipitate migraine can be addressed and they can prevent future episodes. So thank you for your patient hearing and thank you to Rane Hospital for helping organize this talk.